Thank you. Good afternoon, everyone. Firstly, I'm going to say, thank God, the planes finally allowed me into South Australia. I was meant to be here yesterday. So lovely to be here and to see some familiar faces for the first time in the flesh. Today, I'm going to be giving you a brief overview of the Emerging Drugs Network of Australia for those who are unfamiliar. So we'll go through some of the who, what, where, how, why. And then we'll also just dive into some of the current findings that we have over the first couple of years of EDNA. This is testing my multitasking skills, having an iPad and this. So in terms of EDNA, we have three primary aims, and they really tap into the three main pillars, which are looking into some of the tox data that we fabulously obtain from our lab experts, as well as some of the clinical information that we obtain from our network, and then finally going into some of the public health and translational benefits that we get from the information. So the first aim here, it highlights the crucial role that our network of forensic laboratories have. Peter Stockham, who's going to be talking up next, is one of our lab leads. So they do all of the amazing scientific stuff in the background that provides us with the evidence of what people are taking, what combinations of drugs people are taking, and also how this is impacting on acute harm via ED presentations. So aim 2 looks at some of the clinical patterns of toxicity. We have a network of emergency departments across Australia, which I'll show you on the next slide. So the partnership between the laboratories and the hospitals is absolutely crucial so that we can get an idea of, an objective idea of what drugs are causing acute harm. And as I said, and this is where our fabulous partnership with NCRED and the PRN comes in terms of making sure that we share the information from EDNA with the PRN and with relevant stakeholders, and also with people like Paul and peer-based harm reduction. Okay, so just a little nutshell overview of how EDNA operates. So once a patient is identified in the ED with severe and or unusual clinical symptoms of acute toxicity, a blood sample is taken and that gets shipped off to one of our state-based forensic laboratories for comprehensive analysis. I'm not going to try and use any fancy terminology, but we have about 600 or maybe just over, Peter, correct me if I'm wrong, of pharmaceuticals or illicit drugs or NPS, compounds and metabolites. So we have a fair, I guess, reference scope in terms of the types of drugs that can be detected. From here, we collect a ton, an overwhelming amount of clinical information. So we enter the clinical information and also the laboratory confirmed results into the EDNA National Minimum Data Set. So that's hosted at Curtin University in a lovely, secure environment. Okay, so now on to where we're at from a national toxico-surveillance system perspective. So EDNA, I guess the idea was birthed pretty much in 2019, and it came off the back of several state-based systems in South Australia, Western Australia, and we know now that New South Wales and Victoria also have their state-specific systems. But we also realised that it was very important to build or establish a coordinated national approach. So EDNA began 2019, and I was very, very fortunate to have, I guess, been awarded one of the seed funding grants, as in for my employment, not so that was by Jasmine Soderstrom, and South Australia also got an NCRED seed funding grant too to facilitate this work. So The numbers here, that was taken last week in terms of how we're going with enrolments across different states. The variation with numbers is more so representative of our staggered approach to implementation. And I'll just mention too, each state has a sentinel site, but you can see there are several states that have multiple hospitals contributing to the national data set. Okay, the next two slides are screenshots from our National Clinical Registry dashboard. So this has been the most incredibly useful tool, especially for our busy clinicians and laboratory experts, to be able to have visibility within a couple of clicks of the button. And this is updated 5 times a day. So anytime a case is entered into REDCap or the National Registry, it's visible across different states. This snapshot here, it's just shared within the investigator group of EDNA, but there is a public-facing version also. Okay, so we have 2,500 enrollments at the moment. We can see that there's approximately two-thirds, my maths, two-thirds male and 33 median age. Not surprising that the majority of our cases arrive at the ED via ambulance, given that severity is one of the important inclusion criteria, and median length of stay in the ED is 4.9 hours. So if we look at the right of your screen, this is the top 10 illicit and NPS drugs that are currently detected in EDNA. So it's unsurprising that meth certainly rules the roost. We have just over half, or 50% of our cases that have meth detected. GHB is also surprisingly frequent. So a quarter of our cases have GHB detected. Majority of GHB detections also have meth detected. In the top 10, just I'll quickly note the orange bars. So we have 2 NPS in the top 10 illicit and NPS detections, both being novel benzos. Just diving deeper into the NPS detections. So 3/4 of our detections are novel benzos, but we also have a little scattering of some designer stimulants. We're starting to pick up on a few more of the novel opioids, as has already been discussed. I can see the timer. Let me keep rolling through. So some of the NPS detections from EDNA have been used to inform some of the public health alerts, and that's where, again, the PRN and the no community play a really important role to ensure that that information gets disseminated widely and to the right people. So I've just included a couple of examples there from different states. Now, another important goal of EDNA is information sharing. So that's within our investigator group, across state jurisdictions, and we're working on some international connections so that we can share our findings. So I've mentioned the dashboard, very important tool for our investigator group to see what's happening in the data in near real time. We have a quarterly newsletter, and on the last slide, there will be a QR code so you can whip your phones out and take a snap of that if you want to sign up. So that just gives you a broad overview of how we're going with our findings. The no community, we are very much looking forward to continuing our work with the mob and seeing how we can improve our engagement and ensure that the information that we're finding as part of EDNA is also supporting the goals of the PRN. And finally, so like Peter has some very handy connections with the United Nations Office of Drugs and Crime. So we've had just a couple of prelim conversations of how we can potentially share NPS related data with the Global SMART program. An army of collaborators Thank you to everyone. As an absolute beast of a project, but an extreme honour to work with everyone. And thank you to our funders, and I'll just again mention NCRED for your initial support with seed funding and continued support.
Lovely. Thank you, Jeff. Now we're running exactly on time, so just check if there's any questions for Jennifer at this point. Otherwise, we'll keep moving on. Oh, lovely. Oh, you have it. I'm sorry. Yeah. Great. Oh, yep. Oh, we've just got one at the back there. The microphone's there as well.
Thank you for the presentation. Just noting the high amounts of methamphetamine and GHB and male presentations as well. I was just wondering if you gathered data on sexual orientation as well, noting some of the practices amongst men who have sex with men.
Yes, not at the moment. We collect basic demographic information, so sex and age in years, but we don't dive further than that.
Thank you. And one up the front.
Thanks, Jen. I mean, it is a huge collaborative project, and it's something that we really need to actually have some tox data for people experiencing harms related to using drugs. My question, you probably can't answer it, is that what do you think the reach is? Like, what proportion of people presenting with poisoning due to drugs, illicit drugs, I assume, are actually going to be tested by EDNA? Because obviously it depends how busy the ED is, who's on, all of those kind of quality factors. Have you got any sense?
No, personally, and you're absolutely right. It's it's always going to be a limitation in terms of how we interpret the data. As you said, especially over the weekends when the ED is just a madhouse, they're having the thought of this person is an eligible patient for EDNA. Yeah, we can't rely that every clinician, especially some of the junior doctors, are going to remember that and take the time to enroll. So yes, a very important consideration.
Right, and I think it was there one more question. Great.
Just with the high amounts of GHB, is that purely GHB, or are you counting as counterparts GBL and 1,4-BD as well?
Peter's going to talk to that next, but I don't know if there's any, maybe Victoria, and again, Peter, please correct me, any of the labs that can distinguish GHB with precursors. So at the moment, we just report GHB regardless.